Good evening, and this is our, I would say, the first of its kind, like a roundtable meeting on an issue. I think that should interest all the senior people in the healthcare service delivery in our country. I think the evening of 7th of August this year at 7:40 p.m., we all knew that one of the Boeings of the Air India, which was coming from Dubai, had a tragic air accident at the Calicut airport. I think it was one of the biggest tragedy and biggest aviation disasters that we have seen in recent times. It reminded us of the accident that we had at Mangalore airport. And every disaster, wherever and whatever form it happens, I think immediately the unquestionable part on the part of the healthcare to be there to support and to salvage and to help out people. One of the very important players in that direction in Calicut was Aster MIMS, with whom we requested them to share their first-hand experience of how and what everything happened out there. CAHO has a very special relationship with Aster MIMS in the fact that they are our Center for Quality Promotion. And we have had a kind of a continuous relationship with them in the sphere of promoting patient safety and quality in their region. One of their chief of the quality assurance there, Dr. Abraham Memon, I can say that I have again a very special relationship with him because he was the principal assessor in one of the earlier hospitals when I was managing that. And he is the chief of the pediatric and the neonatal surgery there. He's the departmental head and the departmental head of the quality assurance. And when we discussed with him the possibility of doing this kind of an exercise, which could be to stimulate everybody to keep thinking about, because these disasters will not happen at your will or something. We don't want them to happen, but they do happen. And it is very difficult to get a first-hand experience of how things were handled in a disaster. So we requested him and he immediately formed a team of his own, all the people, including his CEO, Dr. Farhan. And we are extremely thankful to them, all of you, sir, for coming forward, and to all the other senior people in the profession to be around and to share this very, very, I think, important deliberations that's going to happen. I will just say that how it's going to play out is, I'll hand over the proceedings to Dr. Abraham Memon, who is going to conduct it, will also introduce his team. And following this, once they are over with their presentations, which we hope will be over in approximately 45 minutes, we request you to kindly raise your hands, or you can put down your questions, and we have requested Mr. Joy Chakravarti, the CEO of the Hinduja Hospital, to conduct the question answer session in coordination with Dr. Abraham Memon and this team. And towards the end, I'll request Dr. Lalu Joseph to say the concluding thing, as well as we have had a kind of a video competition recently, and she will announce the awards for the same, and any other important announcement may happen. We acknowledge the presence of many, many senior people out here, including, of course, our Vice President, Mr. Samir here. And I can see Dr. Upasana Arora. She is the head of our, what do you call that, the Export Promotion Council. and we welcome her. Of course, I have already acknowledged Dr. Atul Kochar. I can already, as I said, Dr. B. Keshav Rao, the head of the Fortis Hospitals, Dr. Sunil Khetrapal, Dr. Vibhu, Dr. Pichumani. You can see Dr. Shaju, Dr. B.K. Rana is another stalwart, the earlier interim chief of the NABH, as well as now heading QAI. I see my dear friend Parag Rindani. So Colonel Binu Sharma. So welcome you all. I'm sure I'm missing a lot of other names. Idea was not to this thing, but I was just spending this time so that more people can join. So thank you very much. And I hand over to my friend, Dr. Abraham Memon. Please go ahead, sir.
Welcome everybody. Good afternoon. Thank you, Dr. Agarwal, for those lovely words and welcome. It is indeed a pleasure to be here to share the platform with you all. The point that you raised is very, very pertinent. Disasters are disasters, and we need to learn from others and their experiences so that we can be prepared in the unfortunate situation that we are faced with a disaster. And therefore, we would like to utilize this opportunity to share our first-hand experience on how we manage this disaster. August 7th was a Black Friday for all of us. Lovely evening, 7:30 in the evening, we get this disastrous news. Aircraft bringing back expatriates from Dubai crash landed at the tabletop airport of Kozhikode. Memories flew back 10 years when similar episode happened in Mangalore. Now, what I have planned for today is there are 6 of us over here who will be expressing their individual areas of expertise on how we were able to manage this disaster successfully. Please remember that not only was this a disaster, but it is a disaster which occurred during a pandemic, probably the first of its kind. And so we will be talking about all these factors. And without much ado, I will start with the opening remarks from Mr. Farhan Yasin, who is the CEO of Aster MIMS Calicut.
Thank you, Dr. Maman. And I also like to thank all the members in this NABH roundtable program to give us an opportunity to explain our experience. And I also thank for the NABH to prepare us to face this event. Actually, as an opening remark, I want to say that as soon as we received the call at 8:10 p.m. on that Black Friday, during the pandemic period, because all the entire beds in this hospital were full, and we were treating COVID patients on that day. We had a lot of COVID patients here, and as soon as we received the call that the flight crash happened, and a call came from the district administration that we have to be prepared and we have to send the ambulance. Quickly, the entire team was alerted, and a crew of ambulance was ready to send to the airport to take the patients. But during the period of hardly around 15-20 minutes, over the phone, we arranged everything. A strong teamwork was there. Suddenly, a counter got opened for as a control cell to manage the telephone calls. The relatives started calling, asking whether the patient is in this hospital or other hospital. So that within 15 to 20 minutes, a massive change happened in our hospital. Entire crew was here, entire staff, all the 300 nurses, all departmental heads with all their junior doctors, even from the top doctor to the housekeeping staff, everybody was ready. Even the canteen was kept open. So that 15 minutes was the major preparedness that we made. When we received the first patient, everything was ready here. And I think the rest can be explained in detail by our Chief Operating Officer, Mr. Samir PT.
So we have got the information, and as the Chief Executive Officer said, we were in no time ready for it. But I'll ask Mr. Samir, our COO, to talk about in detail about how we proceeded from the point of receiving the information down the line.
Good evening. All
Yeah,
of
yeah,
you.
got it. Thank you.
Thank you, Dr. Norman and Kaho for organizing this session. And I just wanted to give an introduction about how we started receiving this information and how we manage the patient arrival and crowd management, media, all these things. So I have just listed a few bullet points just for giving an information about the first initial hours. First, we received a first alert call from Sub-Inspector of Police, Medical College Police Station around 8:10 p.m. So when we received the call, the first thing what we activated is that we sent our mobile ICU and other three ambulances to airport for transporting the victims from the spot. That was the first thing we activated. Second thing what we did is that we informed all our doctors and nurses, and we started receiving doctors and nurses in emergency department before the first patient arrived in the hospital. So this has happened within 10 minutes, and we received first ambulance within 10 minutes of the information. And the first patient reached here was Mr. Deepak Sathe, who was the captain of the flight. And within 1 hour, we received another nearly 35 vehicles. Few patients were transported in ambulance and few patients were transported in public vehicles. So all these patients, nearly 41 patients arrived in our hospital within a span of another 3 hours. And immediately after reaching these patients in the hospital, the triaging was done by our doctors. And whoever was reaching the hospital, they were given a PPE at the front gate itself, so that they will be safe inside the emergency department. The next point which I wanted to mention, very important thing, is that the liaising with the public. How did we manage the district administration, then public, the media, then patient relatives, all. Immediately after this information, first thing what we did is that we started one counter for listening with the public. We kept a big whiteboard outside the emergency department, and we started writing the names and approximate age of the patient who were received in the emergency department. So this has helped a lot for communicating in the initial stage to the public. Second thing what we did is that we have announced a helpline number in which 4 numbers, our manager on duty, including my number, CEO's number. This was published, and this was published in the Facebook page of our MIMS Calicut, and also Aster DM Healthcare Group, and in other social media. This has helped to channelize the calls from the patients, and we were in a position to handle this at the ED itself. The next big big hurdle was the big hurdle which we faced is that crowd management. So whoever was coming here, they were not sure about whether this patient is admitted in this hospital or whether are they the other side. So even if one family member is reaching here hospital, they wanted to get initial information as early as possible. If they are getting an information that, okay, this patient is not available here, they will rush to the other hospital. So that was the big tension or a pressure for our liaison officers and our relations team. So that was managed well by keeping these name boards, and also the approximate age also we have kept. And very interesting thing is that we have done a briefing of each and every patient condition to the relatives by early morning 3 p.m. So that has given a big relaxation to the patients. So whoever is available here, we have given them a chance to take this patient relatives to the patient, nearby the patient, except the patients who got admitted in the ICUs. Then from the district administration and also from this corporation and legal departments, what support we received. First thing is that district collector was on the spot, district collector and deputy collector, they were here, and they were helping us to liaison with the other departments. They have given us a support for coordinating with the other hospitals also. And major, legislative assembly members, MLAs were here. They came here, member of parliament was there, they were helping us. And immediately after this incident, within 1 or 2 hours, district collector has started a WhatsApp group just for giving the information about the patients whoever got admitted. So all the hospitals received the patients, they were putting the information in this WhatsApp group. This has helped a lot for passing this information. And immediately after that, another thing what we did in the hospital is that we found only one patient case which we found very difficult to identify. That was only 1.5-year-old baby. So that was the patient identified at the last, and by early morning 3:30 we identified that baby also. The patient relatives, they were roaming in the other hospitals, and finally they reached here. So meantime the patient body was shifted to mortuary. And after that, medical bulletin we were issued from time to time. We were giving the updates to the WhatsApp group and also the district administration and to the Air India. And medical bulletin was issued from a hospital by Deputy CMS twice a day. So this also was giving a complete details about the patients, what is the condition, all kind of information were passed. Another thing what we did is that we found interesting or helping the patients and patient relatives was we started a mini cafe outside the emergency department. Since through night, the patients and patient relatives, they were staying outside, they were, in the emergency department area. So that also we made available for them. So these are the basic initial, stages of a few hours of the patient arrivals in this hospital. Thank you so much.
Obviously, the clinical management is the most important. And so we will go now to Dr. Venugopal, who is Director of the Emergency Department, Aster MIMS and the DM Healthcare. And we will hear from him about how the triaging and rest of the clinical process was done.
Good afternoon, and thank you, Maman sir. And also thank you for the opportunity. And again, one word about me and NABH, otherwise it will not be complete. Because I'm so passionate about NABH. When NABH started accrediting for the emergency medicine accreditation, I was instrumental to accreditate 5 institutes in Aster Group, that is coming in the first 3 and the 5 and 7. Anyway, so coming to the core point, this was a disaster, the big challenge. This has happened, during a heavy raining. And also 3 issues, the challenge we had while getting the information. All the, all the patients coming in these flights, there are potentially COVID cases. Our hospital was working in a full capacity on those times. We also have COVID patients here. And also, we also don't know about that exact patient going to come. Anyway, immediately after that information, that exactly we get it on 8/21. From that point onwards, that a surge capacity movement has started. And immediately what we did, our ED has got 2 portions, one corona portion and non-corona portion. Corona portion we kept like that, and the non-corona portion immediately converted, and it is converted to receive all the patient, and it is designated the red area. For that matter, all the patients there in the ED are shifted to other areas. Then nearby area, what is called, when we have a nuclear medicine area, that area we converted, is a temporary patient receiving area that is designated in yellow, and 2 floor is designated exclusively for receiving this patient. And then subsequently, also we stopped that existing radiology work, and everything is freeze, and it is converted and dedicated to manage this victim. Similarly, OT, ICU beds, then ambulance already mentioned, pharmacy, blood bank, then CSSD, everything activated. All these people are ready as by before 8:20, everything is ready. And also our store department provided adequate PPE and other materials. So as Samir already mentioned about the bystander media and all, I'm not there. I will give some timeline exactly happened. By 10:22, we announced that MCA, mass casualty incident code, and incident commander took over charge immediately. And then all the resource mobilization, radiology, blood bank, CT, everything is in action. Then I'll tell you so we have 74 doctors, including surgeons, anesthesiologists, ortho, residents, vascular, pediatricians, all the people assembled there. then 76 nurses, and also like 58 other people. Then of the patient, like once the patient started reaching, we received triage out from the ED itself. In the triage area, 17 patients were red in the red category, 19 patients in yellow category, and 7 patients in green category. Of course, like 3 patients broad dead, that include that the pilot and co-pilot and 1 little baby, and 1 patient was in a blue, that is an expectant, that we resuscitated aggressively, but in spite of aggressive resuscitation, declared that within a 2 hour of time. So like then about like the total patient profile that present in the ED, we looking at like this, like 6 majority are the pediatric, belong to pediatric age group, that is like 6 people are under 5, 6 children are under 5, and again another rest of them are 15 children are like between ages between 6 and 18, and rest of them are adult, and only 1 person is aging more than 60. And we have like sex-wise 25 female and 25 male and 21 female, and 1 was pregnant. And out of this, 9 people required ICU admission, and 2 persons required ventilation, and 3 persons required blood transfusion. And again, 21 people required surgery. And the basic injury pattern is 4 people have spinal cord injury, 1 patient with paraplegia, 1 patient with polytrauma, then 3 patients with head injury, and a good number of people that with either pelvic, 4 people with a pelvic fracture, 4 children have that both bone fractures, and again like 2 people with again femur and other multiple fractures. And yes, so 1 patient required aggressive resuscitation, which include chest tube injury, hip dislocations, all these are there. And presently, like we have totally we manage like 47 patients in this scenario. These patients, okay, all these 47 patients we did COVID screening. Our ED itself equipped with the TrueNat COVID screening. It is by early morning 7 o'clock we completed all the COVID screening. Out of these, 2 of them turned out to COVID positive. And one of the biggest challenge what we faced while managing these COVID cases is we have like all of our manage these cases in full PPE. This actually is a big handicap. This really cut off our senses, and managing the mass casualty, this affect our communication, patient assessing, everything is there. But in spite of this, we could manage we hope that it is without any problem. We did that. So that is the things I want to.
Thank you, Venu. So you heard about how the clinical management and triaging was done during those extreme hours. We will now talk about our Chief Nursing Officer, Sheelama, will talk about the nursing parameters and other issues which she had to face.
Good evening to all, and thank you very much for giving this opportunity to share our experience. Providing quality care.
You're not audible, ma'am.
Thank you very much. Good evening to all. Providing quality care to the seriously injured during COVID pandemic was the major challenge for us. But the timely interventions of our experienced medical team and management support helped us to provide comprehensive care to the victims. Our well-defined disaster management protocol, training of employees, and mock drill give more confidence for managing the situation. Upon receiving the information, we have arranged necessary manpower, material, and space. For manpower, we have asked the duty staff to stay back at their respective department and continue duties. Immediate transportation arranged to call the next duty staff. They have reported to ED immediately and provided with the PPE. There were a mix of staff from all departments. and specific assignment and task was given to them by the senior nurses. For material, each department staff are aware of their responsibilities during any disaster. So mobilization of materials happens very early. CSSD staff brought dressing materials from pharmacy, medicines and fluid. Blood bank staff brought blood to emergency department. Same time, enough number of stretcher trolleys, wheelchair and patient cot bed brought to ED by our volunteers. For space, in front of, as Dr. Venu mentioned, in front of radiology and nuclear medicine, we have arranged a temporary facility with the necessary resources to triage the patients. In addition to critical care unit, we have arranged 22 ward bed and 12 rooms to receive the patients. Patients are triaged in ED. Then according to priority, patients are shifted to radiology for radiologic procedures. Seriously injured patients are intubated in ED and shifted to critical care unit with experienced staff. Other patients are treated in ED initially and stabilized. Stable patients are shifted to the pre-prepared ward and room and care continued there. We have ensured all patients are assessed and reassessed by doctors and nurses at regular intervals. During the care, we have ensured COVID-19 protocols and infection prevention protocol. This is from my side. Thank you.
So as you can see, this was a disaster of immense proportions. And to add to the confusion and to the chaos, we had COVID-19 hanging over us. And I will now hand over to Dr. Suresh, who is the COVID nodal officer, to explain more about that factors.
Thank you all for giving me this opportunity. Am I audible, sir?
Yes, you are audible, sir.
Yes.
As our speakers mentioned, it was a very difficult time, pandemic plus a mass casualty. And fortunately, we were able to get prepared because we had a few training in managing pandemic earlier. We made multiple sessions of mock drill and other preparatory measures. So our team members, our doctors, other medical staff, and other supporting staff, all were actually trained to deal with the high number of pandemic COVID cases coming inside the hospital. So the problem which we faced actually was a huge number of PPEs required during that time. And fortunately, we had a very good stock of PPE in our hospital. So I think we used near 1,000 PPEs in the first 24 hours of this pandemic for various reasons. And initially, we had a donning area, which was very small. Then we extended it further. And all the doctors and other medical staff were donned in PPE. And whenever they reached the hospital, immediately we made them to don PPE and be prepared to manage the patients, all doctors and nursing staff, and even the supporting staff. And these patients were initially, all were in quarantine actually, as per the official protocol. All these people who are coming inside the hospital from the flight is in quarantine as per the rule. So we considered them all as COVID positive. And fortunately, our lab is accredited by ICMR and the Kerala government for doing RT-PCR, TrueNAT, as well as antigen tests. And we had enough number of antigen kits. We did antigen kits for those patients immediately. And we also, as Dr. Venugopal mentioned, we did the TrueNAT tests for all possible, and the rest we did the RT-PCR. And we were able to complete the screening by around 7 a.m. in the morning, next morning. And we were able to streamline the procedures, continuous procedures afterwards. And when these patients reached the hospital, we were able to triage them to quarantine areas. We made few quarantine areas in addition to the existing one. And ICU, we already have areas for quarantine or area for isolation. And we shifted them to area for isolation. And another new ward we made as quarantine area, and the rest of the stable patients we managed there. As mentioned, pediatric also, we had an pediatric isolation critical care area where we were able to manage very critically sick, critically ill pediatric population. And another challenge which we faced during this period is the waste disposal, that is PP disposal. So we had an efficient waste management team who were actually disposing it continuously whenever they doff. Doffing time also it was very difficult. One by one doffing was very difficult. So anyway, we were able to somehow manage, and many people to doff they had to wait for a long. So there are such difficulties like that. Anyway, fortunately, we didn't get any exposures, exposure from this huge pandemic, even though we managed more than 47 patients in the hospital. Maybe that's the highest number of patients load a hospital got during this pandemic. Ours was the highest number of patients got during this mass casualty. And after the coming days also, we were able to do the surgery in isolation theaters with negative pressure. And we arranged one more theater to manage the surgeries from the coming days. By 2 to 3 days, we completed all other surgeries. And I think more procedures are waiting in the follow-up surgery center. This is about our preparedness and management regarding COVID point of view. And thank you for giving me this opportunity once again. Thank you.
So there you have the individual personal first-hand experience about how we managed this disaster during the pandemic. We had total of 47 patients who came in. 44 of them came in immediately. A couple of them were transferred later on. Unfortunately, we lost 4. 3 of them died before arrival here, including the pilot and the co-pilot. A great loss to this nation. We lost one more person during the early hours of the day, but after resuscitation, I'm proud to say that our team has been able to save and preserve all lives of the others. At the moment, we have 17 patients in our hospital. We have done over 27 surgeries for various patients, various categories of. Over 70 to 80% of it has been orthopedic. We had, out of these 44, 15 children who had varying degrees of orthopedic and trauma problems. So it has been a disaster of great proportions. What I would like to highlight over here is what has been brought out by all the speakers so far. We were all trained and ready for this. There are 2 things in this earth. 10 years back, Dr. Venu has done a mock drill in Calicut Airport on a similar lines when we had a mock fire and we had over 150 patients being brought to various hospitals. A complete mock was run, and that was a very good baseline for us to have started off. Following this, our NABH protocols, NABH mock drills had kept all our staff on their toes, ready for meeting a disaster. I pray and wish and pray that nobody has to face such a disaster again. But if it does, preparedness is the only way forwards. Just to add to confusion, as Dr. Suresh said, COVID protocols made life even more miserable for us. If you want to know how bad it can be, just try to auscultate a patient with a PPE. You cannot hear anything, you cannot do anything. That was the situation in which we were receiving these 41 patients. The good news is we have been able to do a brilliant job, and I would like to thank, first of all, the management of Aster MIMS for having ensured that the system was in place. The team members, everybody, the team over here is not the one. It is the down the line members who were on the spot doing what is exactly required. 6 hours in PPE is a fantastic time. It's unbelievable strain, but they all managed to do it without violating any COVID protocols. The result of it is obvious from the fact that we have now had so many new successes and patients are now leaving the hospital extremely happy. I would like to thank Kaho and all the others for having given us this opportunity to share our experience, and I hope all of you all will be the richer for it. Thank you very much.
Yeah.
Thank you.
Can we make a couple of comments?
Yeah,
Yeah,
Sadhana, please go on. Yeah, I'll request, of course, Joy Chakravarti to coordinate this part. But Joy, please allow.
Who is coordinating? Joy?
Yeah,
Joy Chakravarti is
yeah,
I'm going to
coordinating,
coordinate
but
this.
Yeah, yeah.
So first of all, I want to thank Dr. Abraham Mamin and the full team of Aster Memes for doing a wonderful job. And it is very nice to see that Kaho has worked with the hospital and identified as a center for quality promotion. And exactly that has been shown, that has been manifested, that has been exhibited during this time of crisis. So well job, well done. So I'm coming to this. I'll be coming to all the participants who are in this Zoom. Will be taking questions either directly or by your chat box. I'm going to get few hundreds are there in the Facebook. They're also going to post their questions and I'll be taking some of those. But without mentioning some of the points, what has been mentioned by all the team members, I can't go ahead. I heard about some of the things like we got people, 74 doctors. The very meticulously it has been told by Dr. Venugopal that 8:21 p.m. So it shows how specifically time has been recorded. It is neither 8:20 nor 8:25. We know in our disaster manual, we talk about different zoning. And I heard very nicely the kind of collaboration which was developed between the collector, local administration, and the hospital. Very importantly, I see the emergency response where mobile ICU and 3 ambulances were dispatched by the hospital at the initial stage to ensure that they get those casualties, those patients quickly in the hospital. And nevertheless, all these were happening in these testing times. I heard 3 patients were brought dead and 1 died after admission, soon after admission within the next few hours, and all have been discharged or maybe under the process of discharge and going to go back home in a healthy condition. So it is a tremendous job which has been done. And I'm sure there are a lot of learnings for all of us. As Dr. Mamin has told, that we should not expect that similar things should happen anywhere, and we need to practice. But nevertheless, the 10 years back, the drill which was done by the hospital, by the doctor in emergency department, has given them the kind of expertise to manage the situation on the Black Friday of 7th August. So without much addition, I'm going to open up the session for questions. I know Dr. Saidullah is waiting to ask the first comments and question. So over to Dr. Saidullah.
Sorry, sorry, Joy. I didn't know that you're coordinating. I came in a little late.
No issues. No issues.
Okay. I only have words to congratulate and my hats off for the disaster preparedness and the response. Samir and Venu and all the team are known to me, and so they have done a great job. I think especially in addition to the disaster, also the epidemic also added a lot of problem. So was there any pediatric cases among these? Venu?
Yeah, sir. I will tell
How many cases?
We had 15 patients who were below the age of pediatric age group, below the age of 6. Remember, this is expatriate flight coming back from Dubai. Most of them were women and children. So we did have a large number. Many of them have fractures of the lower limbs and the pelvis.
Yeah. No. Usually, it's in a disaster situation. Actually, it is a challenge to take care of the pediatrics patients, and because that needs a dimension by itself. Because the general physicians and the ER physicians will be unable to take, and even a number of, I know that there's a number of pediatric patients who are there. And, I was involved a little bit in, because we had about 19 patients in KIMS Al Shifa. And also the BMH also was in touch with me. That's why I was said. And so in general, the crowd management, the information passing on, the government, political people and the authorities working with them, all of them are really a challenge, especially giving information out. I think you did a remarkable job and I want to thank you. Only one question I just wanted to ask, just for the sake of asking. Suppose you critique it and you think you could have done anything better? That's the only question I have, because you have done a remarkable job.
I am sure we can do better. We will be doing a debriefing session in the coming days to look at whatever shortcomings there have been. For the time being, we are resting on our laurels. The fact that we were well prepared and have done a good job. But yes, we will be doing a debriefing to make sure that we can find areas where we can improve ourselves in future.
Yeah, I think CAHO and NABH accreditation helps because MIMS is the first, one of the first hospitals accredited, and certainly, that disaster preparedness helps all of us. Anyway, thank you.
So I move on to the next question, and I'm going to ask Dr. Upasana. She wants to ask a question.
Thank you, everyone. And a special thanks to Team Aster MIMS, because you have done a wonderful job and saved so many lives. I just want to ask you one question. Like in NABH, there is a code yellow for disaster. What do you think at this time of disaster, that code which we are doing in the hospital regularly, do you think that practice was very helpful to manage this situation? My question to Dr. Venugopalji.
Pardon? Repeat.
Disaster code, was it helpful?
Yeah, NABH drills, there is a disaster drill.
It was a big help, because we could be able to manage this pandemic together with a trauma disaster. It's only because of repeated NABH accreditation. Like last 10 years, a decade, we are in quality and quality and quality. Apart from that, as far as emergency is concerned, 5 institutes I personally involved to accrediting the emergency department. So persistently, every 6 months, mock drill, then quality awareness program, infection control program. These are part of NABH, I know. In fact, we will get every 6 months one way or other way, one inspection we will get. So definitely, in hardcore, I would say NABH helped a lot.
Thank you so much. Yeah.
So I have the next question from Dr. Naveen Chuk. He has written, he wants to ask a few things. So you can ask whom you're going to ask the question and try to be brief.
Yes, good evening, everyone. First of all, very commendable action by the hospital, and Dr. Memon, good to see you again. I would just like to ask a few things. I know clinically everything was done as per requirement and a lot of lives were saved. But from the administration side, a few things like after the disasters happen, how are you thinking the insurance companies are treating the documentation which has been maintained? Are they raising a lot of queries, or they are satisfied? Because at that point of time, maintaining documentation, taking consent is very, very cumbersome and difficult, because primarily we want to save the lives. This is one thing. Second one was how did Air India liaise with the hospital? Did they give you enough information about the identification of the patients well in time, or you had to actually run around with Air India?
Okay. You can answer that. The second part of the question, Naveen, hi, missed you for a long time. Nice to hear you. I will talk about the first one, but before that, Samir, our CEO, will talk about the Air India and how they have been interacting with us.
We were getting a very good support from Air India and Air India Express, in the sense they have deputed 2-3 officials to this hospital, and they are still in our hospital. They came here on next day morning, Saturday morning, and from Saturday morning onwards, they are here listening with us, interacting with us. And the specific thing which I wanted to mention is that they are keeping in touch with all the patients and patient relatives and giving them all the support. So financial support they are ensuring. The person, relatives who are staying in hotels outside, they are given the allowances, food allowances, all these kind of things. And they are also interacting with us and our doctors in if there is any concerns patients are sharing with them. So all these things they are taking care of. And still today also Dr. Vinitha, she's not a doctor, Vinitha, she's an officer, she is available today, and we are meeting her morning and evening and giving and discussing all the concerns, and we are sharing the details, patient bulletin, all these things we are exchanging. And meantime, doctors also were interacting with us. So 2-3 officials, doctors came from Mumbai and Delhi. So they were here, they interacted with our doctors, and they have taken, support, and also they have taken the feedback and medical conditions of these patients. And another thing, what they were identified, they were helping us in the sense for interacting with the patients and giving them a console kind of thing. So from our clinical side, we were giving a psychological psychiatrist services and psychologist services. We were giving a counseling. So all these things were taking it forward, and the Air India and Air India officials were very helpful during this disaster.
To add to what Mr. Samir had to say, Air India and Air India Express has done a fantastic support. They have given both logistic and financial support to all the patients, both who are here and have been discharged. In addition, the DGCA top officials have come today. They have come for mainly accident management, on-site inspection, but they will be visiting us also here to get our first-hand information also. So yes, yeah, it has been a very, very cooperative thing from the Air India and the government officials. Going to your first question, this is regarding documentation and consent, if I'm not mistaken, Mr. Naveen, Dr. Naveen?
Yes, yes.
As you know, saving life was priority number 1. So during that day, Friday the 7th and 8th, most of our time was spent stabilizing the patients and getting them stable. Once that has been done, we have been doing the documentation on a slow basis. But it is a process when we are getting there very soon. Fortunately for us, consent was not a big issue because we did not have to take up anybody for emergency life-saving surgery at that point. We had only one patient, the 4th patient, the one who died in hospital during the initial resuscitation, who needed bilateral ICDs put in. Obviously, this was not a situation where we could wait for bystanders or his consent to be taken. So we had to proceed with doing this in the best of faith, Good Samaritan rule. ICDs were taken up, but unfortunately, this patient succumbed to his major trauma within 4 hours of the accident. The rest of all of them have been consented later on and have surgery done accordingly. As Mr. Samir said, one of our biggest issues was identifying these people and giving them a proper name and addresses. Many of them were children who had no idea. That was a big task, which involved identifying them from photographs, having people come and being taken to this bedside of these patients to identify them. But by 3 o'clock in the morning, we were able to identify the last person. The little girl, 1.5-year-old who died. That was the patient we had the maximum difficulty identifying because there was no identity form with her. And she was known by different names to different people, being a child. But by 3 o'clock in the morning, we had identity of all the 41 people. Their bystanders were identified, and each of these patients were independently shown to the bystanders so that their emotional and their physical well-being was looked after.
So thank you, and it is really heart-touching to know about this 1.5 years old child, the way you have managed. So I move on to Dr. Vivek Desai. His question is, during this whole episode, when you have worked, did you feel any time that you need to change the design or hospital infrastructure in which you have worked, and does it require any modification in future?
Sure, sir. We did think about it. But before the disaster, we thought about how we should change the hospital with regards to COVID. So, yes, but then we don't build hospitals expecting disasters every day. So maybe in future, we may have to start thinking of that with the floods every year, monsoon disasters every year. Hopefully not an aircraft disaster, and definitely not COVID disasters in future. We have had enough of it.
So next question is from Father Shaiju. He wants to ask a question.
Thank you, Dr. Joy. I would like to congratulate the whole MIMS team for wonderfully managing the whole situation, especially in this pandemic season. Now, what I understand is wearing a PPE and doing all these kind of services in a very fast manner, it creates a lot of tension for the healthcare workers. How did you manage the whole episode without any PPE breach? Could you throw some light on that? Because many a times I get complaints from the healthcare professional wearing a PPE and doing these kind of services. It's very tiresome and becomes really impossible. So how did you manage?
Father Shaiju, what you said is very, very true. But thing is that we have an extremely active COVID nodal officer who goes around with a wand in his hand and makes strict action even before this disaster happened. Very sympathetic person, very strong person, but very, very correct in his manner. So I will give it to him to talk about how he did that.
Yeah. You feel there
You can write the questions, I suppose. They have.
some failures in PP, breach in PP sometimes. But as far as we know, from the we assessed we examined CCTV footages to see whether there was any PP breach in these areas, because all these areas were covered by our CCTV. So we couldn't find any major breach in PP in the CCTV footages. And the questionnaire also to our doctors and other nursing staff involved, we asked them to inform whether they felt any PPE breach and report themselves. They reported they are all fine with what they did. And we were able to doff PPE within 6 hours in for all people. So the breach was actually, there is no significant breach we could find out.
Nobody turned positive.
Nobody turned positive afterwards also. We already tested most of the people who are involved and nobody turned positive.
2 patients turned.
2 patients already we mentioned that 2 patients were positive. That is, one was resuscitated in ED, and the people who resuscitated also, there was no issue. And the other person who was in MD ICU, medical ICU, was also became positive. But all were considered as COVID positive unless proved otherwise, because they were all in quarantine as per the rules itself. So we were actually managing like that. That's all were in isolation. Thank you, sir.
So thank you. And yeah, so
I just saw a question from somebody saying that, did you follow COVID protocols without knowing the COVID status of these patients? Yes, because these patients were all coming in from abroad by flight. They are technically all quarantined people, technically COVID suspect. So we had to treat them as COVID suspect, even if this disaster was not there. For 14 days, for 28 days after they came back from abroad. So it was all under quarantine, and we did it with complete PPE COVID protocol.
So there is one point, which is coming up from 3-4 participants, that during this entire disaster management, have you come across any learning and you are planning for any corrective action. Dr. Pichumani has asked this question, then the same question indirectly Dr. Atul Kochar, that what is there to improve, what changes needs to be made. So two of them, and from Facebook also the question has come. So what changes you are thinking of bringing, if you have thought about, or maybe you're going to have the review meeting soon. So what is your response to that?
One modification I want to add from emergency side. In fact, the operation side, as like previously in our previous mass casualties and all, we have a big problem that the bystanders rushing into the ED and creating the problem. And so it was very difficult to manage bystanders and media. But this time, that part was perfectly managed by our operation team. Even a single bystander was not there in the emergency department. But I have real problem that there will be a bit of overcrowding in the emergency department, and because of like once the mass casualty announced, a lot of people that some people are not wanted, some people are wanted, but it is very difficult to identify who is who in the mass casualty scenario. So everyone is in PPE. Maybe like in the next mass or maybe in the immediately after, we will make it that paka or 100 or some labels, only like something. I mean the tags that we have to we are preparing. The second point, the another biggest learning, even if our hospital preparedness was excellent and we did manage, and really like if this kind of preparedness was not there, we will lose that golden hour at least for 10 patients. But the pre-hospital area, the patient transport and all not so adequate, and it is not up to the standard. That also our entire team sitting here, we have to focus in India, like it is a more systematic way to how to transport the patient in pre-hospital care scenario.
Thank you. And the next question is from Dr. Samin Mehta. Basically, you know, you mentioned that getting so many doctors in no time, nurses in no time. But his point is, how do you rapidly bring multiple doctors and nurses shifts back on site during COVID times? And how did you manage to do that? Or it was more from ER team response? What happened actually?
We have what we call a trauma code announcement whenever we have more than 4 mass casualties arriving in ED at the same time. So as soon as this information was got, even before the first ambulance was dispatched, the trauma code was announced. The exchange informed all the doctors concerned. The senior doctors were all informed, and all of them independently came to the hospital within 15 to 20 minutes. They were all here and ready. As the chief nursing officer had said, the nurses who were already on that shift were asked to stay on as extra duty for the ongoing period. In addition, additional buses and vehicles were sent to transport the next shift of people. So we had 2 shifts of nurses ready to serve when these patients came in. We had the pharmacy and the pharmacist, the chief pharmacist and his people running and manning the emergency pharmacy, and also getting stuff from the main pharmacy as and when required. In fact, I would like to say, in fact, almost the entire hospital staff was here. Very, very few people were not there, which was another problem, as Dr. Venu said. Sometimes we thought there were too many people over here also. But it's better to have more than a few. Samir, you want to add anything?
So I must say it is an extraordinary coordinated effort amongst multiple departments. The next point Dr. Rama Rajashekaran has raised, that is there any suggestion to add or delete in disaster management protocol? I think that question has come several times and it has been partly answered. And one very important comment, and I can't afford to miss that, from Dr. Gyani. And he has given that, you know, the wisdom that always we work on a correction mode and not in a corrective action mode. So we need to learn from mistake, and need to be prepared better for the next occasion. And he's telling we, in fact, need to move to level of preventive action mode, which requires cultural change. Very thought-provoking words, sir, and we are thankful for that. I move on to Dr. B.K. Rana. He has raised his hand, so over to Dr. Rana.
Thank you, Joy. Thank you very much. Good evening, ladies and gentlemen. And I think, first of all, my congratulations and commendation to entire Aster MIMS team. And how can I forget this hospital when I visited it the first and last time till now in 2006, closely 14 years. And the NABH assessment was the occasion and coordinating, and Dr. Momen, you were there. So I think that visit until today, what I heard from the team about rescuing and taking care of a disaster and the patients in disaster has made me think that that was the right choice to visit as a first hospital for NABH accreditation. So I think all the protocols which you have imbibed from that day, they have been continuing, and that's a good example of how the healthcare quality and safety can be made sustainable. It's not just people talk about it, it's not possible. It is a live example of sustainability of quality and safety on a continuous 14 years. I can say very proudly the 14 years. So I think, as Dr. Gyani also mentioned, is one of the note that this is a high time to pray and look for positive aspects of anything which we are coming across. Otherwise, we are all talking about in negative sense with COVID-19. So I think, once again, my huge congratulations to all the team and management and KAHO to organize this a thought-provoking and a wonderful insight into the real-time scenario of a disaster management. So thank you very much, and all the very best for future endeavors. Thank you.
Thank you, Dr. Rana. And I think you go down the memory lane and you remember your old back experience there. And thank you for sharing that thought.
Dr. Rana, it is a special privilege to see you. Just for the information of everybody, he was my mentor. I hope you remember 1985 Ahmedabad, the assessors course, which put me on the NABH course. Thank you, sir, for that.
I move on to the next question, and that is a request. It is not a question from Dr. Bhagat, as well as it has come from Facebook. So request is, can we see some of the videos of emergency area or triage area? And if it is not a technical issue, then we'd like to know from the managing team that what are the areas they feel there were handicaps. So you can tell, because right now I don't think we can see the videos, but you can talk about the, what are the areas you are feeling little challenged. And at the same time, there is a request from GKNM Hospital, Coimbatore, that can you share the flow documents in terms of your process, what you have followed during this disaster, so it will be helpful for us. So that is a request from the Facebook. So over to Aster team.
Can we defer it till we do our debriefing and then we will come back to you with it?
Yes, I think that is a good thing. You can share it with KAHO, and KAHO can reach back to the participants and share that more relevantly.
We'll definitely do that. So there is one question there which Colonel Binu Sharma has taken up, which I think
I was about to ask that. Yes, I was about to ask that. Very pertinent, and I think it is a nightmare for many of us in case of even not in emergency. How do you manage those belongings and valuable things? So over to Doctor.
Mr. Samir will now talk about that.
Yeah, we had received 5 patients' belongings, which was kept in ICU and also in emergency department. And this was under the custody of our nursing staff. And we handed over these to the patient relatives on 4 days back, after the 4 days of this incident. So I was really surprised, and I was appreciating our nursing team. Even the mobile pin, which is used for opening the SIM port, which was kept in a safe custody in our nursing team, and it was handed over to the patients. So patients were very happy, and this handing over was done in the presence of Air India officials. So they were also available here. And one deceased person, Mr. Sudhir, so his belongings were kept in our emergency department, and we requested their family members. And when we shared this data, when we shared the pictures to the family members, so they were telling that this is not the picture of, shirt or the pant he was wearing. So that was a surprise for us, but we requested them to come over here and identify this, and that also we handed over to them. So total 5 patients' belongings were kept in our custody, and we handed over to the patients after a couple of days.
So next to that, Dr. Sunil Khetrapal, he has a question. Dr. Khetrapal, are you there in the call?
Yes, good evening, everyone. First of all, I would like to take this opportunity to thank Kaho and Aster MIMS for inviting me, or giving me an opportunity to be part of this roundtable meet. And of course, my congratulations to the Aster MIMS team for doing a wonderful job, particularly, the response time and arranging the logistics to management of all the patients. So one thing which is very important during the disaster management is the role of media. So media plays a major role, vital role in management of disaster and dissemination of information. So how did you, my question is to Dr. Venugopal, that how did you manage the media and assigning a spokesperson to providing the right and the accurate information? So how did you manage the media?
Sir, as you rightly mentioned, it is always media will be a problem. But this time I told you they manage perfectly. There will be we interested a single person. Samir and a few other people. So only one person to communicate with the media. That is number. That's a decision was there. That's it's a part of our disaster management. This thing. So only one person is communicating media. Others sir will not come there. So the second one, periodic media bulletin. That is it is twice a day. So one is in the morning. Actually, it's 3 times a day. 3 times the media bulletin we release. And at the time of, at the time of the golden hour period, definitely that our customer care and relationship team to look after all the media affairs, and also social media is also helped a lot in this regard. Rest of thing Samir will help. He's actually the man.
One advantage what we got through this media is that whenever this incident happened in Karipur, so they started telecasting this live in TV channels. So many of our doctors and staff came to know about, okay, so this incident has happened at 7:20 or by 7:30. So we started getting the patients by 8:21. So meantime itself, many of our doctors and staff got this information through media, and they started traveling back to hospital after their duty. This is the one advantage what we got. Another thing is that, as you all know, that media persons are very smart. They are very clever. So immediately after announcing the helpline number, my number was published in the social media, and this TV channel guy who was reading the news, he just directly connected to my number. So I was not knowing whether this is a patient number or somebody's number. So in the live telecast itself, he just asked me, Samir, since he is my friend, he is working in the Cochin. So he just introduced me saying that, Samir, I'm this person. I just wanted to, I know that you are in rush. I just wanted to get a feedback. I told it is I gave next to 10 to 12 seconds brief note. A briefing I gave it in the media in that rush hours.
So one question comes to my mind, and if I can ask to the entire team, how many hours you continue to remain in the hospital before taking a break and going home, if I can ask that?
Okay. We did not take a break. First question, first answer. Most of us, we reached here by about 8:30. Majority doffed by about 8:30. We were all here. I think the last person to leave most of us were sitting over here around 3:30 or 4 in the morning. That is what the time we had. By the time we had shifted the last patient from the ED and triage area to the respective areas, ICU, etc., settle all the bystanders and the apprehensive relations, their problems. The media had gone home to sleep because they had got enough of their information. The canteen was there to serve us hot coffee at that time. So with the lovely coffee and something to eat, we left at about 4 in the morning.
Okay.
Only to come back by 8 o'clock next morning.
I understand. I'll switch over to Dr. Bhujang. Dr. Bhujang wants to ask a question.
Good evening, and a commendable work by the hospital, so I must compliment to them. One question I'd asked and that's already been answered. This also is partly answered because having gone through many, not necessarily the air crash, but many such disasters in the last 35 years, I know the major problem is communication and the public relationship. Especially lots of relatives, lots of media, many authorities, they keep on coming, and then, very, very different thing. So how did you tackle that? No, that was my question.
Sir, this is a very relevant question, and this was the toughest one we had faced. So the reason was, one is this disaster, another thing is that the COVID. So the patients who got admitted into the hospital, they were kept under quarantine, and we were not giving any access to that ward, since we are not sure about who is positive and who is, not positive. So what we did is that we have given even for the patients who got husband and wife got admitted in the hospital. Husband is in a different room and wife is in the ICU. So in all these kind of things, what we did is that we enabled the online, video chat. So that was the work very helpful. So we try to connect all these patients through online video calls, and we help them to communicate and confirm that their relatives are safe in this hospital. And another important thing what we kept in our hospital is that we requested all the departments to route the information, whatever the information we are passing it out through a single point. So that was through the nodal officer, and myself was there, and also from our office. This was centrally controlled so that there will not be any confusion. So even if a medical bulletin was issued by Deputy CMS, Dr. Abraham Amin will prepare, he will come and discuss with our office, and we will come to a consensus, and we will release to the public. So this has helped avoiding the confusions.
So I have only 2 minutes to go, and I'm going to take only 2 questions more. So Dr. Atul Kochhar is going to make a request. So over to Dr. Kochhar.
Thank you, Joy. Dr. Memon, it's been an immensely moving experience to all of us, actually. For all of us who have joined in today, listening to your team firsthand, the entire steps which you've taken, and it's a real testimony to everything which has gone right by the book. The SOPs, the effective communication, the effective coordination, the supply chain. You said 1,000 PPs were made available, starting from the top management. It has percolated top to the bottom, entire permeation of the quality network. I mean, it just highlights you've innovated also, moving from one area to another, then everything from, you've thought of everything. Actually, the team has thought of waste disposal. The team has thought of creating a WhatsApp group. I mean, this is not just a center of excellence. I think it's a culture of quality which is totally pervasive in the state of Kerala, with active support. And obviously, Aster MIMS is the shining star of that example. So this is a wonderful thing. My only request is, if you can just pen down your brief experiences in the form of a article or a stepwise algorithm, it'll go a long way if we could just share it to all our partners. We have currently 9,000 partners across entry level, which do not come into the full fold, and the empanelment. There are about 3,600 such small setups. So they all need to learn from the experience of Aster MIMS. And if you could just give us a short, brief note, it's our duty to take them to experience to all. So please accept congratulations, commendations. I mean, no tragedy. Amidst the tragedy, double, triple tragedy. It was raining also, it was night also, and obviously the COVID pandemic was there. And your team stood up and coordinated and meant when it counted. Counted when. So it's a real thank you. And NABH is tall because of stalwarts like Aster MIMS and you. So really grateful for sharing this experience, bringing us your learning, and we hope to see that videos which Dr. Bhagat said, and so all those things. But please share with us your experiences and your learnings and what could have been done better, as Dr. Shadullah said. I mean, this is the question. And where do we need to change actually? What do we need to change? How can we improve going forward? Were there any bottlenecks in the system which we need to remove? Obviously. So we would be grateful if we can take that learning to everybody, all of us. Thank you so much once again on behalf of NABH. Thank you.
Thank you, Dr. Kochar. And I think it is a very apt thing what you have asked for, which will be learning for many.
Thank you very much for those wonderful words. Just a couple of things. One is preparedness is the key to everything. Two is teamwork. Teamwork without ego. So if these two things are there, preparedness and teamwork, you can go very far. I will definitely arrange for the videos and a post debriefing session later on. Samir is actually ready now with a couple of videos if you have the time and the patience to see it.
I'm not sure whether we should do it here or we should have a separate session on debriefing. I'll request Dr. Vijay Agarwal to let me know whether we should go ahead today or we are planning for.
When will you be ready for the debriefing?
Give us a week, please.
Okay, so then I will invite this entire group on 28th. We are going to have, so there will be a brief session of the debriefing, and it will also be followed by another very excellent kind of a talk by Prashant Hoskote on our organizations alive. It's a very special kind of a thing to motivate the senior people to understand how to bring a different culture in the organization. So we will combine these two things, your debriefing along with a very, very motivating kind of a talk. There is a book which has been written by one Mr. Raghu Kale. It's called Sacrifice and Loyalty, or Loyalty and Sacrifice. Loyalty and Sacrifice. You can look it at Amazon. It is available on the Kindle. It's one of the best sellers. So this talk is based on that. Quite likely we are wanting Raghu Kale also to be present over on that day. Our whole thing is, if we find that talk to be inspiring, we may work out another 2 days kind of a very interactive session with our senior most leaders in the profession. So we will want this entire group to be present for the debriefing along with that particular kind of a talk. We will do that on 28th of this month. So, sir, I think we will take it up then on that day. I think you can show the videos also on that day. And I'll now hand over to Lalu Joseph to conclude this.
Thank you very much, sir, and Dr. Abraham Memon and team. Thank you very much for that wonderful presentation. I must say, you know, the same day I think we reached out to you and you were gracious enough to accept our invitation and present such a wonderful session to us. Congratulations to you and your team. Thanks, Joy, for conducting it so well. May I request all the panelists to please turn on your videos so that we can have one group picture.
And Lalu, also let's have few words from Dr. Girdhar Gyani. Please.
Yeah, sir. We'll do that. Yeah, I just need 2, 3. Yeah. Yes, if everybody can turn on the videos, please.
Dr. Naveen Chok, sir, please.
Yeah, just 1 minute. And smile for the picture.
I put on my mask also, Lalu.
Yes, sir. Do that.
Yes, please.
Dr. Naveen is still not there. Naveen Chu. Yeah. Perfect. Sakshi, have you taken?
I'm taking, no problem.
Yes. Thank you. Thank you very much. And over to Gyani, sir. After Dr. Gyani, I have a couple of announcements on certain results, some competitions that we had. Over to you, Gyani, sir.
I will only say 2 things. One is that I am so happy that we are all assembled here with a positive development, because in this country we are more focused on the negativity, but I think we are celebrating a positive thing. That is number 1. Let me, and Mr. Kochar Dr. Kochar has come here. It is very important because I think it is the NABH standard where we focus so much on the risk assessment, disaster management, and that is helping hospital to develop that culture. I also tell Dr. Kochar, I think he should be knowing that MIMS was the first hospital when we were initially struggling that how hospital will apply for an ABH. Those days, they were the first hospital to apply. So I think MIMS has that culture right from the beginning. And, so I think this kind of senior people coming together to celebrate this success, I think will go a long way. And that's why I said we congratulate Kaho and Esther and NABH here to, they have come together. And I think we should have a lot of such success story in time to come. Over to Lalu Joseph.
Thank you very much, Gyani sir. Your words are always the words of wisdom for all of us and a motivation. And thank you once again, all of you, for joining. I just want to announce the results of the video competition that we had on COVID videos. Some of the hospitals are here, and we had about 9 categories. And Sakshi is presenting that. Donning of PPE, Nayati Healthcare, doffing, KIMS. Dr. Sadullah, you'll be very happy because 4 categories your hospital has won awards. Managing patients in prone, surface cleaning of the healthcare facility including lifts, that goes to Aster Medicity, terminal cleaning after patient discharge to MVR Cancer Center and Research Institute, cleaning of instruments again to KIMS, Trivandrum, managing stress of patients in isolation wards, that's to UN Mehta Institute of Cardiology and Research Center, sample collection again to KIMS, Trivandrum, general video on COVID preparedness to Rajagiri hospitals. Thank you all for submitting videos. We had about 40 entries, and these videos are live now on Kaho Talks. So you can go and have a look at the videos under Kaho Talks. Now the second thing, we realized that this is a very important forum to also launch one of our programs. We are launching a program on risk management in healthcare. It is called as CHRM, Certified Risk Management Professionals, along with ASQA. ASQA has endorsed this program. It is an online program for risk managers. So this is going to be the program, online course on certified in healthcare risk management. Lot of experts sat on this for about 4 months. So it is going to go live October 1st. Registrations are going to start from tomorrow. So thank you very much for the support hospitals have provided to Kaho, and we continue to, embark on journey with training and initiatives that will add value to our partners. The third thing I want to put across is workplace safety. We have launched a competition on workplace safety and worker safety that's going to close on August 31st. This is along with ICMR, NIOH, National Institute of Occupational Health, and GSHP on the measures taken by hospitals towards worker safety. So please submit your entries, and this is going to be a very big event because we are going to be announcing the results on September 17th, which is the World Patient Safety Day. So I encourage all of you to submit or request your hospitals to submit towards this major event. We are receiving submissions from, regional countries as well, from Sri Lanka, from Oman and other countries. So request all of you to encourage your hospitals to submit towards this initiative. Thank you very much, Abraham Mammen sir. Great learning for all of us. All of us agree that we cannot stop disasters, but we can arm ourselves with knowledge. Accreditation is definitely the key, and that will help us to prepare ourselves better. Preparedness is the key. With that note, thank you once again for joining, and look forward to seeing all of you on 28th for yet another wonderful session on the debriefing and also with Prashant. Thank you. Have a very good evening.
Thank you very much.
Thank you.